Okay, well, we'll go ahead and get things kicked off. But we are thrilled to have you join us this evening with the Down Syndrome Association of Delaware and Dr. Seth Keller. This conversation today will speak on neurological complications in adults with Down syndrome. Dr. Keller is an expert within the field, and when some of these concerns were brought up within the parent group, I knew just who to turn to, and Dr. Keller was gracious enough to host this webinar for us. I will turn it over to him in a second, but just some housekeeping. If you can keep yourself muted during the presentation, Dr. Keller is welcome to take questions at the end. If something comes to mind while he's speaking, feel free to put it in the chat and we can revisit those questions at the end if you don't want to forget it. And we are recording this webinar and I will share it with everyone in addition to the PDF of his slides, if that's okay with him,
Yes,
after the call. Great. After the
yes.
call also. Well, Dr. Keller, thank you again so much for doing this for our families. We really appreciate it. I will turn it over to you. And thanks again for your time.
Thank you, Lauren. Yeah, I thank you very much. I'm actually honored to be asked for this presentation. Just a little backgrounder about me. I'm Seth Keller. I'm a adult neurologist. I see adults with various neurologic complications, and I am an adult neurologist. So I don't see children. The youngest that I see in my practice, which is in southern New Jersey, is 18, and I focus on older people. So this discussion within the Down syndrome population is something I see quite commonly, and I specialize, which is really probably a rarity, truthfully, about caring for adults with intellectual and developmental disability, which is a decent percentage of my practice. I'm in private practice in southern New Jersey. I live in Cherry Hill, New Jersey, and I am from Philadelphia. Temple University undergraduate, moved down to Washington, D.C., where I went to George Washington University, and I became a Navy neurologist. The Navy paid for my medical education. I had my family and myself in Okinawa, Japan, as a Navy physician for a number of years. And in 1996, I've been in my current place in southern New Jersey. But my work as a neurologist, and certainly I'll be speaking to you about this topical area, but I do a lot of national and international work in this space. Within my main organizations within the National Task Group, and I'll have some linkage to my organizations. And the National Task Group is a national/international organization that looks at those aging with intellectual and developmental disabilities, and in particular, which I'll be mentioning in some slides, about early onset Alzheimer's disease and those with Down syndrome. But also, I'm a leader in my other U.S. national health organization called the AADMD, the American Academy of Developmental Medicine and Dentistry. And I was asked to speak on various neurologic complications, adults with with Down syndrome and specifically. And I'm going to go through, and it's a lot of discussion, a lot of nuances, and I honestly, for those that are invested in their own loved one with Down syndrome that might have a neurologic complication, I'm going to be spending certainly time speaking about some of these difficult topics, but it's probably not going to be perhaps in details in some, just on the interest of time. And I'm free to kind of be here from now till midnight if you want. I'm open, as Lauren was saying. I know you're muted, but certainly if we have time for questions, that'd be rich. I would certainly would want you to be able to ask questions. So I'm going to just give some general overviews. I have no conflicts or disclosures to report, and you're going to see a number of photographs throughout my presentation that are from my good friend and colleague. His name is Rick Gadotti. So if you have your phone, your cell phone rather, and you can look at the QR code, I'd be honored if you can like look at that QR code, which takes you to the website of Positive Exposure of Rick Gadotti. Rick Gadotti is a photographer who basically is, and as you can see on some of these photographs, he takes really amazing photographs, and it really is on people with developmental disabilities, Down syndrome, and alike, and really expressing them in the greatest values and humanity as possible. I always like to give a present in my presentations some perspective on aging because I do focus on those that are older. Is that people with Down syndrome, people with intellectual and developmental disabilities back many decades ago did not live very long. And this slide really just talked about some nuances over the course of from the early 1900s all the way to current time period about the life expectancy of this population and those with general IDD. The top black line is for a general patient with an intellectual developmental disability, and the one below that in the kind of pink line is those with Down syndrome who've lagged behind. And over the course of decades, what has really taken place in the United States and our society is really a change in social mores, and that's kind of here I am speaking to the Down Syndrome Association of Delaware. So I know I'm singing to the choir based on everyone here who's on this call who really does appreciate the realities of the challenge in this population. And along the timeline, as I did put in some historic note of different factors about time periods, including advocacy organization, which have been very prevalent in helping to support to ensure that people with Down syndrome and other forms of intellectual and developmental disability are living longer. And then also tied into that are various policy efforts that have taken place in the United States, including the Americans with Disability Act and the nuances of your own organization, the Down Syndrome Association of Delaware. And I believe it's from 1979. That's when I graduated high school. So basically, the Down Syndrome Association of Delaware, which was founded in 1979, if I remember that correctly, has been, right there in helping to foster ideals. My other organizations, I mentioned the AADMD and the other one called the National Task Group, they're relatively early on in terms of the history. But be it as it may, all the factors have led to the importance of this population being able to live longer and to be able to prosper. And certainly in that aspect, we are seeing these various complications in the Down syndrome population. And basically what I'm going to be focusing on is several different types of complications listed here. And I'm going to go through each of them. Cerebral vascular, which is blood vascular challenges within the brain. I'm going to be speaking briefly about atlantoaxial instability, autism and Down syndrome briefly. Epilepsy is going to be a big thing I'll be speaking about. And then I'm going to finish it off with functional decline and dementia. And the one thing I'm throwing in early in my conversation is this very important term called diagnostic overshadowing. And for those on the call and in the space that you guys live and support, this is a term that you may be very familiar with because it's very relevant to any medical problem within the Down syndrome or developmental population, and it really has to do with the inherent biases and stereotypes that many, including family members and caregivers and organizations, may have in people with intellectual and developmental disabilities, and thinking if there's some kind of change or problems that arise along the life of them, it's the immediate blaming the change to their underlying developmental disability. So in an instance that they have behavioral changes, they say, oh, it's because they got Down syndrome or they got CP or autism, when in fact it might be due to an underlying health issue. And this is going to be very relevant for most things I'm going to be speaking about tonight, as any complication may be missed or may not be appreciated because it might be this bias and say, oh, this is because they got Down syndrome and this is why they're having it, rather than thinking that maybe there's an underlying health complication that really needs to be addressed. So a lot of the delay in diagnosis and treatment might happen a lot because these lack to be able to come to the realization that there's something really going on. So diagnostic overshadowing is very important. My first discussion point is with vascular complication of the brain, and this is a rare, and I do mean rare, complication called Moya Moya syndrome. And I know that the discussion of Moya Moya was wanting to be spoken about because I have seen this in those who have Down syndrome. And what Moya Moya is, the term Moya Moya is the term in Japanese called puff of smoke. And I'm going to have a slide after this one that's going to show a general description depiction or diagram of what it may look like in the brain. And it's really basically a congenital problem, meaning that this is the individual with Down syndrome were born where there's an irregularity of the blood vessel, the brain that were not formed correctly, leading to complications, which are including stroke and seizures and stroke-like symptoms. And Moya Moya is usually seen early on in the life of somebody with Down syndrome, even though my presentation's on adults per se, is people that have these complicated with Moya Moya may have it throughout their life. But the onset of when someone with Down syndrome may recognize it is basically as early for a 2-year-old or a 30 all the way up to 30 years old. That's when these complications may be seen because they present as either having a seizure, epileptic seizure, or strokes, and that really, is a very obvious sign to the family members who see their individual, their child, who might be having some difficulties that might actually turn out to be from Moya Moya. And I'm going to explain Moya Moya in a little bit. And the way that Moya Moya is looked at in terms of the diagnosis of Moya Moya is looking at the brain blood vessels, and that's by doing a CTA, which is a CAT scan with contrast, as well as an MRI, which is called an MRA, which is an MRI of the brain looking at the blood vessels, but also having a suspicion of it. So there has to be a recognition by the emergency room or by the hospital staff, family members themselves who are seeing their loved one having Moya Moya may not know, of course, that it's underlying a condition of Moya Moya. They just know that their son or daughter or such is really having some difficulties, which could be like a stroke. So meaning that their son or daughter is experiencing, say, one half their body is becoming weak or numb, or they can't talk really well. That would be a sign of a stroke or a seizure, which could be convulsions or staring spells. But the complication for Moya Moya, because of the problem with blood vessel and circulation, is strokes and seizures. There are other health complications, other health conditions that also lead to the possibility of Moya Moya, besides Down syndrome: sickle cell disease, neurofibromatosis, which is another neurodevelopmental disability, but also in individuals that have had brain radiation from tumors and such like that. So these are the issues with Moya Moya, and the treatment of Moya Moya. And this is really as much as I'm going to go into Moya Moya is how is it treated. So the one picture here, and I'm going to kind of, I don't know if you can see my mouse circling around. What I'm circling around is all those red lines, those tiny red lines. That's normally not what the blood vessel of the brain look like, and that's the so-called puff of smoke. The puff of smoke, and this is an exaggeration. This one here is an exaggeration where all these blood vessels are very small. Normally, the blood vessels of the brain are not this thin. They're not that mild. They're very larger, and that differentiate between what Moya Moya is and what the normal brain anatomy is, the brain vascular anatomy. And the treatment of Moya Moya is basically to increase blood flow. And blood flow is called revascularization. And the cartoon or the picture next to the one to the left is showing different. I'm not a neurosurgeon, so I'm not a brain surgeon that would actually operate on anybody with Moya Moya. I'm a stroke doctor. I'm a seizure doctor. So I would see the complications. So the way that the surgeons which would be a neurosurgeon, is to be able to provide an extra blood vessel that either connects to the smaller blood vessel or adapts to the larger blood vessel, and that's called revascularization. And it is a form of brain surgery that adds or introduces an additional blood vessel to the one where the blood vessel is too small. And the outcomes of this, from in terms of a success, are often pretty good. I mean, I wouldn't say it's 100%, but it's certainly not zero. And it's started in this research study that I'm kind of referring to is around like over 50 or 70% in some cases. But the complications are those that will happen if it's delayed, if there's a delay in diagnosis or treatment, when people could have more strokes and what have you. And then even the procedure itself, doing the revascularization, sometimes can have its own risk. And again, this is a procedure that is done by brain surgeons, neurosurgeons. And certainly if you guys have questions on Moya Moya, like on other parts that I talk about, we can get to that at the end. So Moya Moya is one vascular complication specifically, and there's going to be another vascular complication that I'm going to come back to when I speak about aging and dementia. The other complication, which would be somewhat in the neurologic realm, is called atlantoaxial instability. And for us, I suppose, and I could ask each of you, we don't have a large group on the call, if you've heard of it in your son or daughter with Down syndrome, if that's who's on the call, because this is something that is talked about in some respect inherently with Down syndrome. And it really, what atlantoaxial instability is, where the spine, the bones of the spine, instead of it being very strongly knit together, one bone on top of the other, one vertebrae on top of the other, there's a laxity or looseness, and where there could be a slippage of the bones of the neck, causing compression or compromise of the upper part of the spinal cord. And back in the day, and I've been doing this for 30 years, and I do work connected with Special Olympics. There's always screening, and people with Down syndrome, there's like x-rays that we've done. And if they have a propensity for atlantoaxial instability, there's warning to individuals with Down syndrome about participating in contact sports. But really what it is, the data that Special Olympics has accumulated over the course of 20 years, is that it's rare. The complication of atlantoaxial instability causing some kind of complication, such as spinal injury, is rare. So we think about this situation that when people with Down syndrome go to their pediatrician, they transition into adult care, is physically, are there signs that they have any compromise of their neck? And the signs of any kind of compromise would be someone that has their legs become weaker, their legs become stiff and tight, their reflexes get more exaggerated. Those are signs of what would be called spinal cord compression from these laxity within the cervical spine. But these conditions are very rare. Even though atlantoaxial instability in itself may not be rare, having it as a real complication is actually very rare. It's really not common whatsoever, as we thought years ago it was a problem. I have a slide, and I did also want to talk about the concomitant connection between those with Down syndrome and autism, and certainly, and I don't know if anyone on the call, I'm not the pointing fingers, anyone on the call, a parent, that if you have a son or daughter that has Down syndrome, do they also have associated symptoms and signs that they're also autistic? And there is a rather not a tiny prevalence between autism and Down syndrome, and there is a commonality, and I've seen it quite a bit in my practice. And I think the challenge in many situations in those with Down syndrome, children, young adults, or older adults, is to differentiate between and this goes back to diagnostic overshadowing a little bit, is the behaviors that your son or daughter has of Down syndrome, are they autistic behaviors as well? And I'm saying it in somewhat of a rhetorical way, because in some respects it's not really that defined or that clear. There's a lot of written description and mention in literature about the connection between autism and Down syndrome, and there's often a delay. There's often a delay in being certain about autism and those with Down syndrome, and a lot of it is because of the fact that it's not really that clear between one or the other. There's not easy assessment tools that kind of differentiate the two, and certainly in terms of the severity of the symptoms, that also might have an impact upon if it's more obvious or not, if there's really autistic behavior. I'm not a psychiatrist. I only see autism in some respects in my Down syndrome population as a complication that might be happening if they also have seizures, which I treat, or if they have aging and dementia, which I treat, and if they have autism in their Down syndrome, that would have an impact upon my own assessment or ability to care for them in some regards. I am a seizure doctor, so I do want to speak a little bit about seizures. Seizures, and I'll just use this one term here. A seizure is the individual specific event of an electrical short circuit of the brain. That's a seizure. And in someone that has more than one seizure, and they are prone to having more seizures, that's called epilepsy or a seizure disorder. And those with Down syndrome absolutely have a higher risk of having seizures or epilepsy throughout their lifetime, starting in very young young populations as early as early birth or in their first few years. There is a high risk in early on because of the developing brain and the kind of seizure that may happen in those that are very young or young children is something called West syndrome. And West syndrome is a type of seizure where the individual, their child, has spasm. They tighten up. They specifically have a semi-type convulsive event, and they have a certain brainwave EEG pattern, and that's often a very poor prognosis, meaning that for their seizures they might be hard to control. It might affect their cognitive abilities more than other children with Down syndrome, and they might carry this type of a seizure condition that might evolve throughout their lifespan from a what's called a spasm up to more generalized tonic-clonic seizures or other seizure types. And that's really the commonality between seizures in children and young adults with Down syndrome. But the one that I see, which is really relevant to me as a an aging neurologist, is what's called late onset myoclonic epilepsy. And myoclonic epilepsy is a kind of seizure where the individual has what are called myoclonic jerks. And what myoclonic jerks are is almost like a quick spasm, a jerk of an arm or leg, and often that the individual might even fall down because they lose body tone. And this can happen in anyone with Down syndrome, but if it does happen, certainly in their 40s or 50s, that is a very concerning factor because that often is seen in those that are now beginning to develop decline in their ability, which is basically Alzheimer's disease, which I'll be speaking about. And myoclonic seizures are a difficult seizure because it is hard to treat. Some of the medication we use, what are called the anti-seizure medications, sometimes they don't work as well, and they can also have certain complications from the seizure medication. And myoclonic epilepsy in those with Down syndrome with Alzheimer's, it's often a worsening prognosis that more decline can occur. So I've seen it quite a bit, and it's a very unfortunate situation. It can be very challenging. From a seizure standpoint, generally there are in the developmental population and those in Down syndrome, there might be these syndromes. Other type of syndromes was one called Lennox-Gastaut. I mentioned West syndrome. The individuals might have a different kind of seizures. They might not all be just a jerking or a staring spell or falling down. They might have multiple kinds. They might have seizures that lead into what's called status epilepticus, which means that the seizures last more than a few minutes and they ongoing. And if that happens, they can have breathing problems and problems with their blood pressure. They can have clustering of seizures, meaning they have a seizure, a few minutes later another seizure, and a few minutes later another seizure. That's called clustering. And then individuals who have seizures might also be on anti-seizure drugs or anti-seizure medication for lifelong, and that might have side effects from the usage of it for a long time. In this population, polypharmacy or multiple medications, both used for medical problems and epilepsy, are often very common. And if the individual has side effects such as stomach upset, tiredness, cognitive difficulties, in someone with Down syndrome who might be poorly verbal or nonverbal, the individual may not be able to express or say, oh, I feel sick or I feel bad. And some of the difficulties that they might manifest are behavioral changes because they just don't know how to express, and this is how they react in some respect. I did mention the idea about diagnostic overshadowing is very important to appreciate that this is something, there's biases that all of us can get into that might help or rather distract from coming up with the right diagnosis because of the biases and not really being sure that anything you're noticing is it from their Down syndrome or is it underlying a condition that's happening. Side effects they're having, I mentioned that in terms of this issue as well, maybe not easy to know or clear about. And then the data collection, how do we really know or count about the seizures, important. And as an adult neurologist, there's also the importance of transitioning from the pediatric physician to an adult physician and ensuring that the adult physician, primary care specialist like myself as a neurologist, that the adult physician understands the Down syndrome population, that they themselves, will they be trained? Will they be knowledgeable? Will they help answer your questions? And then one last picture here on the slide is this one comment here that I add in a lot of my slides from this philosopher pharmacist physician from the late 1400s, 1500s, who basically made this comment that I think is very relevant. I always put this in my slides, talk about medications. All substances are poisons. There's none which is not a poison. The right dose differentiate poison from a remedy. And the reason why I thought that's very important, it has a lot to do with anything that any of us takes. Over-the-counter medications, prescription medication, they might seem okay, but anything, if you do too much, too strong, it can cause complications in that individual. So I always think it's important to kind of talk about the nuances of these various treatments. So the last thing I'm going to talk about, and I'm definitely going to leave a fair amount of room for conversation because I'm going through this kind of quickly, is the decline. And this slide speaks on the concept of what's called functional decline. Functional decline is when the individual is declining in their functionality in their lives. Their ADLs, or activity daily lives in particular, they're not able to do it like they used to do, and they're declining. And this is called functional decline. And for me as a physician, as a neurologist, when someone's having functional decline, that means they were at a higher level of functioning before, and now they've lost ground in their ability. And for a physician, as someone that comes to see me to say Mary or Joe is not able to do what they used to do, is some of the difficulties could be maybe it is normal for that individual, maybe it's not a condition of a pathology or disease, but if it is, these are the different categories that we as physicians think about of why the person might be having signs of decline. And across the top, the orange boxes are those types of conditions that might lead to functional decline, such as cognitive difficulties might lead to decline. And that could be dementia, that could be strokes, they could have had head injuries, that could be seizures. If they're having sensory difficulties, that could be hearing difficulties, visual problems, balance difficulties. Neuromotor, what that means is basically difficulties with their bones and joints and the nerves. So people who, and I mentioned this in someone with atlantoaxial instability, something called myelopathy. What that is basically, it's pressure put on their spinal cord, their neck, and that is really what I've alluded to. That's called a myelopathy. That's a spinal cord compression. They can have pinched nerves, which is called a radiculopathy. They could have increased tone. They could have a muscle breakdown. And then under psychiatric is they can have individual mental health problems such as depression. They can have anxiety, self-injurious behavior. So there could be a psychiatric difficulties that could arise as well. And also, I should really add some of the autistic behaviors could be part of that as well. And then general medical problems, they could have heart difficulties, hormonal difficulties such as endocrine, ADRs is adverse drug reactions. They can have heart and lung problems. So there's a plethora. There's actually a fair amount of difficulties that anybody with Down syndrome or others can have. And in certain situations, the individual can have multiple reasons of decline. So it may not be from one single reason. So when I see individuals with Down syndrome and change is occurring, the question is why? Why is changing occurring? And this is just a slide showing these, these photographs of different ages of people with Down syndrome. It could be really normative. It could be normal for them, or it could be a disease of some sort. But what's hugely important, I know that for everyone on the call, you certainly appreciate this, is to knowing that person. You have to know that person. I'm telling you all this because you certainly are supporting somebody with Down syndrome, is know that person. What can they do? How well can they do it? And that's really what information is huge for me as a physician who may not know that person too well at all, to see that they used to be at a higher level of ability and now they are not at that same level. So that's why, as a caregiver, as a family member, and I know you all know this, is telling that to the healthcare provider that, oh, my son or daughter, they were not like this before. This is what they used to be like before, life story, and now they're different. And that's kind of where the advocacy and the voice of you all are so rich to really tell us, hit us on the head and tell us something's going on, something's not right. It's important for us healthcare providers to understand what are the other health complications or health comorbidities that your son or daughter has. Do they have vision problems, hearing problems, emotional difficulties? Are they on various medications for their health problems, such as thyroid or others? So understanding their health condition and other treatment for them is very important. And the other part about is the psychosocial elements around the individual's life. Where do they live? Where do they work? Has there been factors going on in their own environment that might sign or be as a trigger that might be a reason why decline is happening? So maybe, God forbid, there's a parent or a sibling that got sick or hurt or moved away, or if they are working and there's a change in the work environment, or if they're living in a home or group home or with you, that maybe there's something within your home environment that also might triggering the change. But also the concerns of dementia and Alzheimer's, which I'll be speaking about. And then again, diagnostic overshadow, I think, raises its head all the time in trying to recognize clearly if change is really happening and not blame it on the underlying condition. One type of cognitive decline I really wanted to mention before I speak about Alzheimer's disease is what's called a Down syndrome regression disorder. And I don't know if any have heard of it before, but it's a rather rare situation in those with Down syndrome, and it can happen early on, a 10-year-old all the way up to maybe a 30-year-old. And it's really where someone within a rather short amount of time, weeks in a few months, is where they lose abilities, they regress, they lose skills, and where they can lose their own ability to talk, communicate, their behavior might be very different. And that's called the Down syndrome regression syndrome or disorder. And that is not Alzheimer's disease. This is not. And some of the triggers that seem to occur in people with Down syndrome that in some respect might seem to cause some of these is like an emotional trigger. But sometimes the trigger of why these mechanisms or such happen is unknown. There's a thought in research that it might be an underlying immune mediated or autoimmune condition, and the treatments that have been looked at to help bring that person back or keep them from getting worse are often based sometimes on not only behavioral concerns, but on the possibility that there could be an immune cause of their immune system. So some of the therapeutics that have been tried and looked at, and this is an ongoing field of research, is usage of immune treatment, such as immunoglobulin or other aspects of inflammation to reduce inflammation. But definitely from a mental health standpoint, there's lots of research that looks at the usage of tranquilizers such as benzodiazepines or antidepressants or lithium even. Electric shock therapy has also been thought to kind of help in these conditions. So this is a very difficult condition. The prognosis of regression is the hope of stabilization and try to eliminate or try to bring your son or daughter or whoever may have regression back to a prior level of functioning that they've lost some skills in. So the prognosis overall is variable. It really depends. And I have a little bit experience on this, but not a lot, truthfully. I haven't a lot. My expertise is really related to Down syndrome and Alzheimer's. That's kind of really, for me as a neurologist, I work both nationally and internationally in the Down syndrome Alzheimer's space, which is really what the last few slides are going to talk about. And it's never an easy conversation to talk about this because it's not like a happy, excitable kind of conversation to talk about this, but there's a huge prevalence, a very high prevalence of the connection between Down syndrome and the beginning of Alzheimer's disease, all related to trisomy 21. You all know trisomy 21 certainly, and it's the extra chromosome where because the three different chromosomes of 21, a protein that is often made off of the trisomy, off of chromosome 21, is beta amyloid. Beta amyloid is a protein that we all have in our body. We all have it, but unfortunately, in those with Down syndrome, because the extra chromosome 21, people with Down syndrome begin to have a buildup of this microscopic protein called beta amyloid starting in the 20s and 30s and 40s, and it goes up exponentially where the beta amyloid into itself begins to injure and ruin and have a negative impact upon the brain structure, the neurons and the electrical conduction of the impulses. And that leads basically to what Alzheimer's is the beginning of a decline in cognitive functioning starting at some point in the late 40s, early 50s. And the prevalence is, I usually say, 60% by age 60, and it just goes up after that. So this is a huge issue in the Down syndrome population, and this is kind of where a lot of the work that I do and the complications is that is that it could be a rapid progression, where from the very beginning of a sign of decline, as the individual could have a rapid sign decline and it could progress quite quickly, leading it sadly enough and tragically to death. It's till their death. Those that can make it even worse or more complicated and it's already bad enough are seizures, and I kind of alluded to those myoclonic seizures, and that's the connection to that. Late onset seizure, which is the one I was alluding to, if they have associated vision problems, hearing difficulties, sleep disturbances, behavioral problems, these all add to additional complications for individual with Down syndrome. The assessment for this issue is understanding the signs of decline, is to really recognize, like I mentioned in any other aging related thing, is the life story, all the factors in terms of the medical problems, how did it start, what has really changed, does it run the family. Caregivers definitely are hugely important to understand what you say and what you're noticing. That's going to be very important. And there's a tool, and I can give you a link to it, called the NTG Early Detection Screen for Dementia, which is a questionnaire that families and parents and caregivers fill out, usually starting at age 40. And what it is, it's basically is a questionnaire saying that, has your loved one, someone that you care for, have they had a change in their functionality? Have they shown change? It doesn't mean that they might have Alzheimer's. It's really to open up the conversation that they need to see the doctor, who can then test them for other possibilities of why changes occurred. Is it from B12 deficiency? Is it due to depression? Is it due to sleep issues? Is it due to thyroid, etc.? So these are the tests that would be often recommended if they have not done before, to look for these changes that might be causing the problem that they're facing. The future for diagnosing Down syndrome and Alzheimer's is going to be based on what's called biomarkers, and that's what this slide is. So, as in my involvement both in the research world, is really talking about Alzheimer's disease. And one thing just to let you know is there actually is a presentation tomorrow that myself and my colleagues are going to be putting on through the National Task Group, and I can put a link to it. Lauren, did I send you that link?
Not yet, but if you send it, I'll share it in the email too.
Yeah, so this is a free webinar, and I apologize for telling you now, but it's actually tomorrow. And the webinar specifically is going to get into great detail about this topic. Biomarkers, which are the biological measurements of Alzheimer's in this population, is going to be spoken about a lot. And then also related to the therapeutics. So you're going to hear about they're going to hear about the therapeutics. I'll be talking about that. And then the other complication, we're going to open up the floor for questioning, is this other complication of the blood vessels in those with Down syndrome, which is called cerebral amyloid angiopathy. So the protein of amyloid isn't there only to kind of affect the neurons, leading to compromise, leading to Alzheimer's. It can actually affect the blood vessels in the brain, leading to strokes and bleeding in the brain. And this is an additional complication that, aside, I mentioned Moya Moya as an early risk factor for children and what have you, is this amyloid buildup can also cause like strokes as well. And this is a very important issue, of course, for the individual, God forbid, having strokes, but also has a lot to do with these new treatments that are going to be coming out for Alzheimer's disease, which are called the anti-amyloid treatments. And the anti-amyloid treatments are those medications, which is this slide right here, are these medications that are used now in the future for people that have the beginning of Alzheimer's disease. And this is a busy slide. It really just talks about, in the center picture is the pathology underlying brain of somebody with Alzheimer's, and it really shows a neuron, which is that, how could I even describe it? This is a bird-like kind of creature with these arms sticking out of it. That's what a neuron looks like. This is blown up in a large way. These are microscopic, and the neuron inside the neuron are these blue and purple things, and this is called the synapse. The synapse is the connection between one neuron and another neuron, and the brain releases the various chemicals which lead for us to kind of lead to communication between the brain to brain cells. But in people with Alzheimer's, these communications become off and wrong and bad because of the fact that these neurons are not working correctly. And in the past, the treatment for Alzheimer's disease is giving drugs called one called Aricept, another one called Namenda. These are the names on the right side, and these have been traditionally used for years and years and years. Unfortunately, in those with Down syndrome and Alzheimer's, there's really little research that these drugs have made much of a difference at all. But the new anti-amyloid drugs that I'm alluding to, which are to their bottom here is called Leqembi and Kinsula. These are two new anti-amyloid drugs which are FDA approved for early onset or at least early mild to early Alzheimer's. And the one that's blacked out called Aduhelm or aducanumab came out first, but it was taken off the market because it really didn't show much of a value or benefit. So the two available drugs, and there is research studies going on now, which I'm showing on this slide, are research that's being done currently in those with Down syndrome to see if any treatment can affect their underlying brain in terms of reducing amyloid, helping them with Alzheimer's symptomatology. And so here's a QR code that will take you basically to kind of what this slide is. It really talks about where these research studies where you can go to find out more information about that, and that's what the slides are. In those that have Alzheimer's disease, I'm looking at the avenue of trying to make a diagnosis. And what's going to happen in the future for people with Down syndrome is going to be a pre-symptomatic diagnosis, meaning that with the advent of biomarkers and the knowledge that there's such a high prevalence of Alzheimer's and Down syndrome, is to be able to even know or make a diagnosis that they have Alzheimer's before they even have it. So there will be in the near future the ability to tell I hate to say lack or not, that's not a good way to put it, is really be able to get a diagnosis before you even have symptoms in your 30s or 40s or 50s, before they're even symptomatic, by doing these biomarkers, these measurements of proteins either in the blood, in the brain, or spinal fluid. But definitely the goal will often be is once cognitive decline happens, what could be done about it? Behavioral supports is often behavioral complication, depression, anxiety. I mentioned seizures as another thing that would have to be looked at for treating people, but also wellness, health promotion, and living well with dementia. And that includes caregiver supports for the family members. And then the research. I kind of showed you that slide with the QR code that talked about research. Caring, obviously, overall for the individual and for you all is hugely important. And I know this is kind of an obvious slide: respect, being valued, speaking about the person. I use this slide in my presentation for physicians and other ones, and so I'm speaking to them about what they should do and what they should not do. And not to be pitied, not to look down upon, don't be stigmatized or marginalized, and all that. And really treat them as an individual with respect. And obviously, I know that's very true for you all. And in this slide, I want to show you this, and I'll just finish up right here. So these are two images of two individuals. The one in the blue shirt in the wheelchair with two individuals next to him. He's unfortunately with Down syndrome quite impaired, and the one to the other side, the one with the light green shirt surrounded by actually his family behind them. Both of them are individuals with Down syndrome, and they might be individuals that I might see in my office without me ever knowing them before. And I might think, oh, this is how they live and this is how they've been, when in fact, these are pictures of those same individuals that had a full life. The one with the hat and the glasses and the jacket, that's Bill Hogan. And Bill Hogan was a brother of a friend of mine, Mary Hogan, and really that was Bill. Bill had this wonderful life, big part of his family, and the one individual with his arms raised up, that was Marty Sheets. And Marty Sheets was a Special Olympics athlete as he's there, and it was a major weightlifter in Special Olympics, and he basically won medals. He was almost like the poster child of Special Olympics, very close to Tim Shriver and the family, and he was used in promotional work. But unfortunately, the reality is both Marty Sheets, who basically sadly enough passed away, as Bill Hogan, they developed Alzheimer's disease. So each of them had full lives, but tragically they led to their complications. This is a slide that has some of my reference information. All my slides will be given to you, and you can have information about the QR codes or in linkages to the sites that I'm mentioning about. So I think what I'm doing is I'm going to stop right here. And in the interest of time, I want to make sure in our audience if you guys have any questions for me. So Lauren, that's my run through of my slides. And I get, again, I think it's what quarter of, I think we got time.
Thank you. Yes, that was perfectly timed. We have one question in the chat so far. I'll read that first, and then folks are welcome to unmute themselves and ask the question, or if you put it in the chat, I'll read it aloud too. This question says, I have noticed my child with Down syndrome and autism spectrum disorder slowly declining in function. At what point would this be a concern, or when should I address it with the doctor?
Well, I think it's all relative. So I think there's change and there's change. So when I even specifically mentioned regression, regression in that respect is happening over days, weeks, and a few months. So that into itself is super dramatic. So that would be, I'd say that's a super dramatic change in that situation. I think, and everyone's going to have their own story to tell. It's all relative to what you notice in terms of when should you address it. And I guess I'm a parent, but neither of my kids have any developmental disabilities. So what would I do if my child has any kind of change where I'm basically worried about them? So I think it really depends on the degree and change that's happening. That's the best way I can really put when should you raise the alarm bells in your own mind. It depends on the degree. And also often what I also you certainly as a parent appreciate if you bring this up to your practitioner, or pediatrician, or otherwise, what is it that what should you expect that you're going to get as a response? What do you want to get as a response? What do you think you're going to get a response? And I say it in that kind of rhetorical way because one, you want to make sure that the healthcare provider, the doctor, the pediatrician really respects what you're seeing, and I know you all know that. And also, you also want them to not over test your child because certainly I'm sure it's not that easy to get blood draws or get testing and all that. So I think it's all a matter of degree and also respectful that the healthcare provider is respecting what you're saying. So I think that I would say that's the most important things that you see it for what it is. And if you have concerns, then you really need to bring it. And as you all are advocates, is persistence. I know you're all very persistent people. I'm sure here you're on this call and you're part of the support groups or other this organization. So again, I think it's important to make sure yourself is well heard.
Great, thank you. Any other questions from the audience, or feel free to unmute yourself and ask
I mean,
directly.
I'd be curious, and I don't know if I can take a poll or not, Lauren,
I
is
think we
is
can.
all those that are on the call, are you parents or caregivers of children, or are you caregivers of those of adults or adolescents? Because I don't really know myself who you all are. I mean, I'm not. I don't know if you want to, Lauren. I don't know if you know that.
I can do one real quick. Yep, just give me 1 second. I will say that there's quite a few parents of, I would say 30-year-olds on the call just from the names I recognize.
How
Uh,
old did you say?
30-year-olds with Down
Oh,
syndrome,
I see.
about
Okay.
30. Yep.
Okay.
Okay.
Yeah, I see people putting it in. Yeah, it's certainly as parents, and I guess a lot of them are parents on the call, what you might be concerned about as a parent of someone with a very young child with Down syndrome, or someone with an adolescent with Down syndrome, or a young adult or an older adult with Down syndrome, you're seeing it. You're seeing the differences that you all are going to appreciate. And I don't think it changes so much in terms of you, whatever age you are as a parent to your loved one with Down syndrome. But the reality is that there are certain, again, an aging brain doctor. So there's a lot of work that's being done in aging with Down syndrome, a lot. It's not a great situation with early onset Alzheimer's to say the least, but there is a lot of work and research that's been going on. And I think the one thing is really certainly appreciative in someone who is supporting someone with Down syndrome, and your individual is say in their late 20s and 30 years old, is to really appreciate about wellness and health promotion. There's actually a fair amount. I appreciate that about Moya Moya surgery and certainly revascularization. I'm sure you can talk about that because I'm assuming that's kind of surgery that they had received. But definitely, having the awareness of change is very important, and the healthcare provider, especially on the adult side, to really recognize and express to the healthcare provider that my son or daughter, this is what they used to be, and I use the term the best performance, their best ability, and what they were able to do in their lives when they were really, at their top of their game in some respect, and that's important to know what their good baseline is. What could they really do? And as you're beginning to show some sign, oh, here we go, some polling here.
I think I did it. We'll see. How old is your loved one with Down syndrome's the question. So we did under 10, 10 to 18, 18 to 35, 40 plus.
Oh, you're quick. All right. So, well, okay.
35 plus.
Okay.
But definitely for those that are having children that are 18 to 35 years old, and 40 years old, certainly anybody, anyone, you're going to hear more and more and more about research, about biomarkers. And I don't know, and Lauren, I don't know how you pass it on in terms of your group. Is that something that you guys speak about a lot, or do you start talking about that in your population or in your group?
So that's something that I was going to ask you directly too. I think I see a couple parents on here that have children that are younger, and I think the main question we hear from them is just what testing should I be asking my doctor for and at what age? Like when should I really start being concerned about this? Obviously being on this webinar is helpful, but I'm sure it also can be a little overwhelming of all of these things to look out for as they get older as well. And I'm sorry, I missed the 35 to 40 age gap in the webinar. So, in the poll, so just do if you're between 35 and 40 for that 18 to 35.
Yeah, and
Um,
I did see that one question. I mean, there's a few questions about the connection with Moya Moya and higher rate of Alzheimer's. I have
okay.
not seen that at all. I mean, first of all, Moya Moya is very rare, and I
Hmm.
think all I can say is that these are complications that I'm assuming if someone had Moya Moya, had they had a stroke, and if they've had a stroke, what does that mean for them if now you're adding on to concerns of decline in their functionality? That would be a concern. The other part that would be very concerning is that if one day there are these new drugs, these new medications to reduce amyloid or to prevent amyloid from building up, or an anti-amyloid treatment is having a pre-diagnosis of moya moya or complication of that amyloid protein, what would that mean? I think that's going to be the big issue, is that would that prevent them from getting treated? And that might. Because what it is that the risk of these new anti-amyloid drug, the risk of the treatment, well, first of all, the benefit of the anti-amyloid, that's what they're called, anti-amyloid drug, which are intravenous shots, is they get rid of the amyloid, microscopic amyloid in the brain. And when that's done, the individual who might show signs of decline or Alzheimer's, is the medication helps them improve in their difficulties with Alzheimer's, and it might prolong their life in a good way. And then as they're getting older, is that they can keep getting anti-amyloid treatment and could keep pushing further and further their decline. And as the research gets better and better, there might be better medication. But the complication is that when these anti-amyloid drugs are given to remove and eliminate amyloid in the brain, it can lead to increased complication of bleeding in the brain and swelling. And that's where people with Down syndrome might have more complications. So right now, there's research in those with Down syndrome, specifically separate than general adult population, because they might have more risk to get these treatments, and they might have different outcomes of these treatments. So there's these research, as I alluded to, that are going to go on that are going to get a fact for those that are younger right now, and in the one you're supporting, that their future may be very different for those that are living now in terms of what they can get, and even the prospect. And this is not science fiction; it's not hyperbole. Is that it's very possible that most individual Down syndrome, starting at age 20 or 30, in the future, they might all be given an anti-amyloid pill or treatment, so this never really will happen to them. And again, wouldn't that be something?
Hmm. It looks like we have another question in the chat as well. They have a 25-year-old child with a son with Down syndrome who's been given two different diagnoses, one of Alzheimer's and then one of regression disorder, and the mom is struggling with what do you think her path should be if she's getting two different answers from two different doctors? Sorry, yes, one with Alzheimer's, one with Down syndrome regression. And
Well,
is 25 too early for an Alzheimer's diagnosis? And
Alzheimer's is impossible. So it's
okay.
it's it's impossible. It's no way. Alzheimer's would never happen in someone with Down syndrome at 25 years old. Regression, that's where regression fits in. So, but Alzheimer's is, I'd say, I'm going to just come out and say impossible. That's impossible.
Mm,
There's no way. So if they're saying it's Alzheimer's, that really says a lot about the practitioner doesn't know. They just don't have the knowledge about or the experience, and they just may have only heard about some kind of connection. But it's definitely not Alzheimer's. And just to use the word, I see the question, dementia versus Alzheimer's versus Down syndrome regression. Is it really what's the difference between what's the difference between Alzheimer's and dementia? So and I kind of use that a lot because people don't often know the difference. Dementia is in older people, older adults, not not in 20-year-old person really, is an older adult that is showing progressive decline, which is like a regression, but an older adult in such, and then they need more help. And that term is having a dementia. But when someone's having or getting dementia, the $1 million question is why? Why does that happen to them? So for me as a neurologist, the testing that I do on individuals that are showing decline is to look for the reason for it. Is it from vitamin deficiency? Is it from sleep apnea? Is it from all the medication they take? Is it from depression? Or is it actually what's called a neurodegenerative disorder, which is what Alzheimer's is? Alzheimer's is a degeneration, a breakdown of the nervous system, and that's the number one reason why anybody anywhere gets a dementia from a degenerative disorder. And there's multiple different kinds of neurodegenerative disorders. The most common of them is Alzheimer's, and it's called Alzheimer's dementia. Another kind of a degenerative disorder causing dementia is Parkinson's dementia. Another one is called Lewy body dementia. There's a few other ones, but these are neurodegenerative disorders. And in all the people with Down syndrome, in all the 30 years I've done this, I'd say that 99% of all people with Down syndrome who get a dementia, it's Alzheimer's dementia. It rarely, there could be other problems like one called normal pressure hydrocephalus or such like that. But by and large, the predominance of cases in individuals with Down syndrome who get in their 40s and 50s and such, it's from Alzheimer's dementia.
okay. Very interesting. Yes, I've definitely heard from multiple families that they've gotten conflicting diagnoses for one thing, which I think just shows the lack of education from some of the providers.
And
They
that's what
all,
I do, Lauren. So in my role as a neurologist, here I am giving you talking points. I do educate other providers. So in my work within the American Academy of Neurology, within my work in the American Academy of Developmental Medicine and Dentistry, is sharing information. And it's all a matter of sharing information for those that are still in medical schools, that are in universities, that are already in practice. And it's a matter of getting out information to those that are already in practice for them to want to learn. So it's a
Mhm.
matter of getting it out there for those that, are caring for people down syndrome anyway, is to say, well, how they have to reach out and want to be taught. So
Yes.
if they're not interested in being taught, then that's not good.
Yes. And on this call, we have at least three families that have loved ones diagnosed with Moya Moya, which is really
That's
interesting to
rare.
me.
I mean,
Yes,
and that it is a rare situation. So it is rare, even though you're seeing it within you on the call, but
sure.
it is a rare thing. And again, in the 30s, 30 years I've done this because I'm an adult health provider. I have seen people that have Moya Moya, and I have tested many adults with Down syndrome for Moya Moya because of the thought that they could have had it or will have it.
Okay, looks like another question just came through. My daughter started having what was diagnosed as syncopal
Syncope.
episode.
Yeah,
Thank
syncope is
you.
fainting. Say syncopal. Yeah,
Okay.
that's fainting.
Okay, syncopal episodes at the age of 17. She
Yeah,
had MRA because I was concerned about Moya Moya and
yeah.
neurologic beliefs. Do you want me to read the whole thing?
Well,
Um,
really what it is that the reason why someone may faint is they're not getting blood flow to the brain. So if they're not having good blood flow to the brain, their blood pressure doesn't get up in the brain and they faint. And that could be, it's not the most common reason for fainting, but a lot
okay.
of people with Down syndrome, they might have a slow heart. or a primary heart issue, and that usually is the case. I would say Moya Moya, I wouldn't say it's the most common reason, but again, if you're not having good blood flow to the brain, that will cause you to black out. That's not as common as like strokes or seizure, which is the main reason that Moya Moya is seen.
Okay. And she asked, is an MRA the best test to determine if they were seizures or not? She hasn't had any more episodes in 2 years. Is there
Well,
anything else we should be
the test
asking?
for seizures is an EEG, a brainwave test. So MRA and also a CTA, they're imaging only of blood vessels. So there, and the difference between an MRA and the difference between a CTA, one's an MRI and one's a CAT scan, and it's all a matter of what's tolerable to your son and daughter. MRI is a loud machine, it's more enclosed. A CAT scan, a CTA, is easier, but it involves an injection of contrast. Not that that's a horrible thing, but there's a logistical difference between an MRI machine and a CT machine, and so it becomes practically what's easier for your son and daughter to tolerate any of these. But technically, I think the data or the clarity of the results of an MRA versus CTA is like the same.
Okay. Okay. Would anybody else like to vocalize a question or put it in the chat? I'm happy to read it. She said, thank you, Dr. Keller.
My pleasure. And I'm available. I mean, here you can reach out to me. I don't know if I put my contact
I saw
information.
your email address on one of the slides, so I'll be sure
And I
to.
do want to also, and maybe, I do want to make sure that you all know about, a correlation between clival chordoma and a moya moya. I'm not familiar about that at all, about a connection between these. They're both very rare situations, so I've never heard of that connection. So that's very unique. I can't explain that at all. I do want you all to know, and if you have, I say nothing better to do tomorrow night, the NTG, my organization, is putting on this big time presentation, and it is tomorrow. And let me see, as I'm doing this one, let me see if I can just send to you a link to the course because it really is tomorrow. Here it is. Let me see here.
Yes, if you put in the chat, we can share
Yeah,
it.
here I'm going to here. I think what I'm going to do, this is probably the best way I can do this. It's probably not the best way, but I'm sharing my screen. Do you see this here?
Yes.
So here's a QR code to tomorrow night's webinar. This is the one I'm speaking about. So please, if you're interested, this is free. This is tomorrow, and this is a QR code, and I'll be on. My name is not listed, but I'm one of the main organizers. And these are people who, like one of them in particular, in perspective, and I know all these are good friends of mine, is Margot. And Margot, she's one of the leaders in the National Down Syndrome Society. Emily Largen, she's at the University of Pennsylvania. She's very involved in IDD and bioethics. Brian Chicoine is a primary care provider. He's in Chicago. He leads a center there. He leads a Down syndrome medical interest group around the country. Bowen Anses, he's a researcher and neurologist out of Washington University who is going to be giving a lot of great information about updates in biomarkers and research. And then my colleague Lucy Ezerlou, she used to be in New Jersey with me. She's a neuropsychologist. She's right now in Northern California. She's helping to be the moderator. So this is going to be tomorrow at 5 to 6:30 tomorrow. And honestly, please, 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 if interested, right now we have over 500 people from around the world that have
Uh,
registered for this course tomorrow, and it's a webinar just like this.
I put a link directly to it in the chat as well.
Wonderful.
Barbara, I did put the link directly. I scanned the QR code and put it in. So you will
Perfect.
put that link. One of the parents asked Dr. Keller if they would understand it. Is it in scientific speak or is it in plain language?
It's
And
meant for families. It actually
okay,
is. So
great.
we do. I mean, I appreciate that question. Is it really technically complicated? I mean,
Yes,
I can't say that there's not some technical parts that might be a little
sure.
complicated, but we definitely purposely knew that many people, if not the majority of people, are going to be people like yourself, family members, caregivers, community-based support people. We definitely deeply appreciate it. So it's not, even though there's some science, yes, involved, we're going to make sure that we make it user friendly to you all.
Sure. Okay, and I'll post that in our parent group to Dr. Keller, and I did put the link to it there as well.
Thank
Thank
you.
you. That's timely. We
Well,
definitely.
folks, I gotta run. I'm actually on call. I'm getting a call to the emergency room. I gotta answer my call.
Well, I appreciate it. I will follow up with everybody with your email address, but Dr. Keller, thank you so much. We all appreciate it and have a great night.
All right. Thank you all so very much. All right, bye.
Thanks.
Gotta
Bye.
go. Thank you.
Okay, everybody, I will follow up via email with the link to the webinar tomorrow, as well as Dr. Keller's email. As you can tell, he is a wealth of information and happy to chat with any of you if you have specific questions. He's very personable, so please feel free to email him or email me and I'll connect you with him. But thank you all for being on tonight. I appreciate it, and have a good rest of your night. Thanks so much.